I would like to invite our next speaker, Dr. Atul Batra. Dr. Batra is Associate Professor, Department of Medical Oncology, All India Institute of Medical Science, New Delhi. He did his MBBS from Maulana Azad Medical College and MD Internal Medicine and DM in Medical Oncology from AIIMS, New Delhi. His major research interests are in prostate cancer, breast cancer, renal cell cancer, and germ cell tumors. He is life member of many societies like American Society of Clinical Oncology, Canadian Society of Medical Oncology, among many others. He has authored more than 60 original papers, research papers, published in national and international journals. I now invite Dr. Atul Batra for his talk.
Thank you, Dr. Anisha, for the kind introduction. And I also want to thank the organizer and chairpersons for the invitation to this beautiful conference. And I myself actually have learned a lot of things over the last sessions about the basics. You keep using such drugs, but it's always a pleasure to go back to the basics and understand what's happening with the epigenetics. So I think I'll share my presentation and start off with the topic that has been given to me. So my topic is more of the what's happening with the clinics using these agents that target the epigenetic mechanisms and what has been their role in treatment of cancer, and specifically about the demethylating agents in cancers. So if we talk about hypomethylating or demethylating agents that are abbreviated as HMAs, and we actually use those terminologies only. And two such agents are available, which are actually widely used in clinics. Those are azacitidine and Deceta Bean. And these are actually cytidine analogs, and that actually incorporate into DNA during the S phase of cell cycle and bind to DNA methyltransferase 1. Thereafter, they degrade and deplete within the cell, and thereafter causing reduction in the methylation of CpG residues in the genomic DNA. This leads to the alteration of epigenetic pattern and modification of the gene expression. They have a clear role after several phase 2 and phase 3 trials were conducted in MDS, CMML, and acute myeloid leukemia. So this slide summarizes whatever I have said till now about their mechanism of action, that these are basically cytidine analogs, and they incorporate into RNA and DNA, and thereafter causing hypomethylation, change in the genetic expression, and thereafter leading to a differential gene expression as well. So if we look at the FDA approval of agents in MDS, azacitidine and decitabine were actually game changers in the treatment of MDS. For MDS, that is myelodysplastic syndrome, there were actually not much therapies that were available. So in the low risk MDS, the only treatment that used to exist was the wait and watch and give best supportive care till these diseases will evolve further either into AML or would remain dependent on several transfusions or growth factors until these agents came into picture. Azacitidine was the first agent, and then Deceta Bean. Now we have had a good amount of clinical experience even from India, and we have been using these agents quite on a consistent basis. So if we look at the treatment management guidelines for low-risk myelodysplastic syndromes, so these low-risk myelodysplastic syndromes are basically, they would have either a single lineage involved, and the patients would be symptomatic with either thrombocytopenia or anemia. And the first line treatment would usually involve now giving thrombopoietin receptor agonists. And if they fail in the second line, then hypomethylating agents can be used in patients with thrombocytopenia. Similarly, if we look at patients who have anemia but do not have the deletion 5q, so patients with deletion 5q actually respond very well to lenalidomide. And but those patients who are without this deletion, again, they are supported either by erythropoietin, and if it fails, Deceta Bean can be used. And we have used these agents in patients with refractory anemia as well, where we have seen remarkable responses, and these patients have a long-lasting response with these agents. Not only low risk myelodysplastic syndrome, when we look at those with higher risk MDS that have a very high risk of progression towards AML and are symptomatic with usually more than one lines with anemia, thrombocytopenia, and as well as neutropenia as well. So here, the patients are usually classified as transplant eligible or ineligible. Patients who are transplant ineligible are classically treated with these agents, either azacitidine or Deceta Bean. And further, if such patients are transplant eligible, could also be treated with HMA, which could be followed by a allogenic stem cell transplant. Now, this was with MDS. Now, with the evolution of role in MDS, clinical trials were set in to look at the role in AML as well. So AML management is divided into patients who are either eligible for intensive therapy, who are usually treated with regimens like 3+7 or Flagida or other regimens, which are very intensive. But patients who are not eligible for such intensive chemotherapy regimens have an option of being treated with these agents, either as a single agent or in combination with several targeted therapy. Like if the patient has IDH1 or 2 mutation, then IDH1 2 inhibitor and Deceta Bean can be added. And along with this, oral agent, that is venetoclax, has also been shown to have an improvement in the outcomes of such patients. So not just MDS, AML treatment is also, we are seeing now evolution of the role of HMAs here. And even for those who have actually achieved complete remission with these intensive regimens, we'll discuss how elderly patients have benefited in maintenance therapy. Now, if we go to the evidence of how these agents actually evolved in the management of MDS as well as AML, there are several trials, and we'll briefly touch upon the landmark trials that showed improvement in either the overall survival or improvement in the symptomatic or quality of life in these patients. So to begin with, these were CalGB 8221 and CalGB 8421. These were phase 2 studies that established that a median of 4 cycles of treatment was needed to elicit any kind of response in such patients. So if we look at the classical therapy for AML, it is usually 1 cycle of induction. Some people do agree with the second cycle, although it's more equivocal kind of evidence for that. But when we use the HMAs, it is usually a median of 4 cycles when we would expect some kind of a response to occur in these patients. This was then followed with CalGB 9221. This trial basically established the role in patients with MDS, and these patients included refractory anemia with ringed sideroblasts, refractory anemia with the excess blast and end transformation, and CML patients. These patients were randomized to receive either observation, which used to be the standard of care then, and azacitidine. The dose used here was 75 milligram per meter square daily for 7 days, and this cycle was repeated every 28 days for 4 cycles. Now, crossover was allowed once the patient was out of observation in the observation arm. The response was, the therapy was continued till response, and here we saw that patients had complete remission in 7% and partial remission in 16%. Hematological improvement was seen in almost a third of patients, and there was a delay in the time to development of AML by almost 9 months. So 12 months in the observation arm and 21 months in those who received azacitidine. This was compared with best supportive care, where hematological improvement was seen only in 5%. So this trial kind of established azacitidine as the standard of care in patients with MDS, where reasonably good, almost more than half of the patients got transfusion free, and the progression to AML was also delayed. Now, the second trial, that was ESA 001 trial, this was again a multi-center international phase 3 randomized control trial. And this also included patients with high-risk MDS, IPSS 2 or high, intermediate 2 or high, and most of the patients were actually RAEB, RAEBT, or CMML. These patients were treated with azacitidine in the first line. So the previous treatment was not allowed, and the treatment option was predetermined by the physician. So in the experimental arm, azacitidine was given in 179 patients, whereas conventional care was as per the physician discretion, which included best supportive care, low dose cytarabine, and 25 patients also received intensive chemotherapy. So patients who are actually RAB or RABT were usually treated as AML earlier, and that's why some patients actually did receive intense chemotherapy in the conventional care arm. So the median age of these patients was 69 years, and 72% was actually over 65 years. The survival at 2 years was doubled for patients who received azacitidine. So this was 51% versus 26%, and this was statistically significant. Also, the time to leukemia transformation was around 1.5 years as compared to 1 year with the conventional care. The gold standard outcome that we are always chasing in oncology is the overall survival was again almost 25 months, 2 years with azacitidine vis-a-vis 15 months with the conventional care. So these two trials actually established that azacitidine as the standard of care in patients with MDS. The dose and schedule that is followed is 75 milligram per meter square for 7 days, every 28 days. And the benefit of giving azacitidine is that it's a subcutaneous drug, so it can easily be administered on the outpatient basis. Now, coming to the other drug, that is Deceta Bean, this is the injectable form, and it is basically an analog of azacitidine. Various drug dosage schedules have been used with Deceta Bean, which has varied for 5 milligram per meter square to 45 milligram per meter square in this trial. This was the first phase 3 trial that was again in patients with MDS, and around 89 patients were in the Deceta Bean arm and best supportive care in 81 patients. And here again, a similar kind of complete response was seen in 9% and partial response in 8%. But hematological improvement, the most important outcome I feel in MDS, that was seen at around 25% of the patients. And transfusion independence was seen again in almost more than 1/3 of the patients. Now, the other regime that we were talking about that we actually use most of the time is 20 milligram per meter square for 5 days and given every 28 days. So this was used in a phase 1-2 study, and they escalated the dose from 5 to 20 milligram per meter square. They found the best response rate of 39% with the 20 milligram per meter square dose. And this is the most commonly used dose schedule for Deceta Bean. Here, CML, there were 19 patients and a CR rate of 58% was seen in those with CMML. Now, if we look at the oral azacitidine trial, now this was the excitement area where oral azacitidine was developed, and patients who were AML with intermediate or poor risk cytogenetics who were treated with intensive chemotherapy first, which could have been followed by consolidation and were transplant ineligible. So basically patients with AML, intermediate and poor risk, CR after induction chemotherapy, consolidation plus minus, but no transplant. These patients aged more than 55 years in the first emission. These patients were randomized to receive either oral azacitidine, 300 milligram daily for 14 days, and this was every 4 weeks. So 14 days on, 14 days off, and this was continued vis-a-vis placebo. So, and response assessment was done every 3 cycles. The primary endpoint here was overall survival and secondary endpoint being relapse-free survival. So we could see that when we look at the overall survival, there was a difference of 9.9 months, where approximately 25 months versus 15 months that was seen in as the primary objective of this trial. And when we look at the relapse-free survival, again, a difference of around 5 months was seen, 10.2 months versus around 5 months in the control arm. So among older patients who achieved remission, using oral azacitidine maintenance could prolong their relapse-free survival, as well as, more importantly here, overall survival. So this patient group, actually, if we talk about, is a very poor outcome group, because these patients have intermediate and high risk, but are transplant ineligible. And are elderly. So these patients usually have a median survival of around 15, 16 months. So with the use of oral azacitidine maintenance, this could be improved to over 2 years. And again, oral azacitidine was associated with consistent survival benefit regardless of the number of prior consolidation cycle. So irrespective of whether the patient received consolidation or no consolidation, the patients in both kind of patients did benefit. They also did an analysis looking at whether minimal residual disease could affect. So patients who had minimal residual disease versus those who did not have minimal residual disease after the induction. So complete remission is one thing. When we look at deeper response, we call it minimal residual disease. So those who have minimal residual disease have a worse outcome compared to those who do not have a minimal residual disease. So it was looked at whether this was interfering in some kind of the outcome, but both the population, irrespective of whether they had minimal residual disease or not, benefited with the use of oral cytidine as a cytidine maintenance. So overall survival as well as relapse-free survival both increased irrespective of the MRD status. So overall, it reduced the risk of death by around 30% and risk of relapse by around 43%. Now, further, after looking at the benefits after induction therapy in transplant ineligible patient, this was extrapolated to patients who actually received stem cell transplantation after induction. And this was a small trial and looking mostly at the feasibility, because post-transplant period, it is a difficult time. There are several drugs that patients are receiving for their GVHD prophylaxis or treatment. And so this was more of a feasibility trial to look at whether these patients were able to tolerate and oral azacitidine after transplant. So some patients received 200 milligram daily for 7 days and 300 milligram for 7 days, or 150 or 200 for 14 days. So overall, it was well tolerated, and further phase 3 trial is ongoing to look at the actual efficacy outcomes. So this was only to look at mainly the tolerance, and further evidence is needed actually to recommend it post transplant in such patients. So another trial, a certain trial where oral, this is a combination, we call it as Seedec, that is a Sidazuridine and Deceta Bean versus IV Deceta Bean. So to make it more patient friendly and convenient for the patient. So this was kind of an equivalence trial where they looked at the levels of Deceta Bean after giving oral versus IV therapy. And this was a crossover trial. And here, when they looked at the oral versus IV AUC ratio, it was actually 98.9%. So this established almost the equivalency of the oral formulation of Deceta Bean as well. Again, the same study where we could look at the survival outcomes are also similar, and it was not different, although it was a small one. So again, I think we can all these phase 2 and phase 3 trial with oral Deceta Bean versus the phase 3 trial with the IV Deceta Bean have shown almost similar kind of results when we look at the outcome measures in terms of relapse-free survival as well as overall survival. Further, there are other trials of oral azacitidine in combination with other drugs, also looking at in combination with venetoclax with or without placebo. These are the ongoing trials where we are expecting the results to be presented or published within next few years. So times are going to be exciting, where we are also, I think, going to look at its role post-transplant in combination with venetoclax, in combination with IDH1 inhibitors. So it's going to be a more personalized kind of therapy, even in AML, where initially we had just mostly 3+7 or low dose Ara-C as the treatment. So now, after the usage of HMAs for a long time, now the time has also come that we are also talking about development of resistance to HMA. Now, this resistance can either be primary, that the patient does not respond, or secondary. It has been seen that if the patient develops a secondary resistance, that is after using azacitidine or Deceta Bean, if you use the other agent, there is some amount of response that has been seen using the alternate agents. But within the primary resistance, there is usually no response using this other agent. And there are several studies where we are looking at how the resistance is developing and how we can overcome the resistance and what are the agents that can be used in the second lines. There's exciting future with the epigenetics, of course. We looked at so many agents in the previous talk that are being developed, and use of NGS techniques to identify what all therapies can be used to identify what's happening in the first line and then in the second line, EZH2 inhibitors, IDH1, 2. So a lot of things that are going to come up in future. And I think apart from genomics, epigenetics is another thing that we are going to be looking at in the future studies. A lot of ongoing trials in combination with chemotherapy, newer agents being developed with the HMAs, with previous agents like bortezomib, lenalidomide. So lots of exciting stuff going on. And the results of these trials would be out in next couple of years. And we would be seeing a lot of change in the standard of therapies that we have been following for last several years or probably decades with the use of newer agents. So I again thank the organizer and the chairpersons for the invitation and the opportunity. Thank you.
Thank you so much, sir, for such an illuminating talk.